So I recommend watching this at 2 times speed. I'm going to run through about 90 different questions. They're very high yield. They're from many different questions. None of this is copyrighted material, but it's a bunch of notes from very, very high yield content. I've done all of the step 2 questions for UWorld, all the questions for AMBOS, all the questions for osmosis, a bunch of different QMakes, really almost everything I can get my hands on, and these are some very good questions. And they're also newly added, which suggests that it's from research that they have identified that these are questions which come up on the exam, which take that for what it's worth, but it sounds to me like someone did some research and found that their question banks were insufficient to cover some of the questions that are being added to the step 2 exam. So if that were the case, then I would pay close attention to the questions which are being added. These are the questions which are being added. So without further ado, here we have a question that wants to get to the bottom of what to rule out in the case of kind of deficiency symptoms, which can be kind of like psychiatric and can have to do with reduced, pubic hair or like hyponatremia, hyperkalemia, if you're salt craving. And so this is the sort of question where you want to rule out some disease with a test. And so how does the test work? What is Adam's disease? First of all, it's primary adrenal insufficiency, right? And so what is PAI? It's primary adrenal insufficiency. And so you would diagnose this by giving synthetic ACTH. And then if you had low cortisol after that, when you tested the cortisol levels, then that would suggest that you had PAI, which is primary adrenal insufficiency. The reason for this being, if your adrenal glands are not doing what they're supposed to be doing, but ACTH is at a reasonable level, you would suspect that that ACTH would stimulate an increase in baseline cortisol. But if that's not the case, then you likely have PAI. So what toxicity similarities in terms of symptoms do lithium and benzodiazepines have? So the symptoms that they share, there's 3 of them really. And so there's ataxia, there's lethargy, and there's slurred speech. These are the things that both lithium and benzodiazepines will have. So what would you expect if the person only had a lithium toxicity and not a benzodiazepine toxicity? There's some things that are kind of unique. Is like you don't classically associate GI upset with benzodiazepine intoxication, although of course you can have it. Nystagmus is really a lithium experience. We're not talking about withdrawal, we're talking about toxicity here. So we're talking about an overabundance of the drug. So there are situations where you can get in association with these drugs symptoms like this, but not in toxicity. And so toxicity is very specifically an increase. So GI distress, nystagmus, tremor, and increased reflexia, meaning your like deep-tended reflexes are increased. All right. So red urine, what do I do? So this is very common in hospitals, so it's good to pay attention. So the first thing, if you see red urine or a patient that comes in with red urine, you want to do a urine dipstick, right? And so the result, let's say the result is red-brown with heme positive, then what? So you want to do a urinalysis next. What are you looking for? So if it's greater than or equal to 3 RBCs, then you're calling it hematuria. And if it's less than 2 RBCs, then it's hemoglobin or myoglobinuria, which can lead to rhabdomyolysis, right? So what do you do for uncomplicated paradigmatic effusions? So I always spell things like this. I'm sorry, guys. so that I can think about it differently. So what do you do for uncomplicated paradigmatic effusion? So serial X-ray for uncomplicated. So if it's uncomplicated, you do serial X-rays. This is paradigmatic effusion. That's an effusion that happens within your pleura, between your two layers of pleura. So what if they are positive? They are positive cultures enough to do diagnosis. Is that enough to diagnose a complicated? The answer is yes, it is. So what do you do if it's complicated, right? Well, you want to drain antibiotics. So those are the two things. Right? And then posterior urethral valve. So this is a very, very common cause of oliguria, and a very common cause of kind of hydramnios, right? And so you get reduced urine output, and you get oligohydramnios potentially. Distended bladder. So this is like a Potter sequence type thing, because when we're talking about posterior urethral valve, it's basically like a wall. Okay, it's like a hymen. You guys know what a hymen does and how it works, but it's basically like the posterior urethral valve, usually in a young boy, is going to be like a membrane that literally occludes the urethral, the entry point from the bladder into the urethra, prostatic urethra. And so you can get Potter sequence where if you're not urinating enough, you're not breathing or inspiring enough, quote unquote urine. It's not really urine, into your lungs. And if you're not getting that incompressible fluid it inspired into your lungs, then you're not getting that cellular hyperplasia that you need in order to get mature lungs at that age, at that time in development. And so you develop respiratory distress symptoms in Potter sequence. So the patient presentation of posterior urethral valve is usually respiratory distress, bladder distension, and decreased urinary output. So dry cough plus progressive pain in the shoulder and ulnar nerve distribution. So that's C8 to T1. And so prospective lung diagnosis. So this is just superior pulmonary sulcus Pancoast tumors. So there's not much to say there. If you get a Pancoast tumor, you might have pain in the shoulder and pain in the ulnar, like C8 to T1 nerve distribution. If you like these Unicodes, macros that I'm using to take notes, let me know and I can share how to do that. What do you do with hyperventilation syndrome? So hyperventilation syndrome refers to someone who's not quite having a panic attack, or call it a panic attack. It's like a situation where they are breathing not for pathological reasons, not for physiologically pathological reasons, but they're breathing to the respiratory rates increasing, and so what they need to do is decrease their alveolar minute ventilation by decreasing their breathing rate. And so what you do is just breathing training. You don't use a paper bag, which is one of the ways they trick you into getting this question wrong. They used to try to get you to breathe into a paper bag for migraines. So if your ejection fraction is below 30%, then it's life-limiting, and surgery is not necessarily worth it, because surgery might exacerbate your chances of survival, and your morbidity and your mortality might get so low that it isn't worth doing the surgery. And So that was just a note that I took on this particular question, because it's counterintuitive why, if your ejection fraction is below 30%, that you might not do surgery. I'm just going to put a not symbol here. So it's not indicated. Whereas, like, if you're symptomatic with below, so specifically symptomatic and below 30% life-limiting, surgery is not worth it. Indicated, I should say. Whereas asymptomatic and left ventricular ejection fraction above 60%, it's not worth it because the morbidity and mortality is not high enough to justify this like intense intervention. So surgical repair is such a risky thing in and of itself that you have to consider the risks and benefits of doing it. So you need to be between 60 and 30% and symptomatic. What is a very common cause of bilious emesis in infants? So infants being between birth and 12 months of age, which is 1 year. So intestinal malrotation is the answer. So there are probably many answers to this question, but intestinal malrotations are very, very common. It's the differential is immature lower esophageal sphincter, which lower esophageal sphincter, and this would lead to a spit up that resembles the foods that you ate, and so you wouldn't have bilious emesis. Okay. Then FACE syndrome is an acronym for posterior fossa brain malformations, hemangiomas, arterial anomalies, cardiac. So, posterior fossa brain malformations, hemangiomas, arterial anomalies, cardiac defects, and eye abnormalities. So FACE is, this is a note I took on a question that I didn't think was high yield except for the acronym FACE, which is kind of like Vactoril, it's like a bunch of associated pathologies that, if you know about them, can help you answer any of these 5 pathologies might be associated with any of these 5 pathologies. So you can get a question where its eye abnormalities are associated with cardiac defects, arterial anomalies are associated with hemangiomas, and so you usually get 2 or 3 or 4 of these in one question, but it's nice to know what all of them are. So what I like to do with lists like this is I like to create a little P, so P, H, C, E, and then so PO, just so I can remember later when I go over it. So I just like to teach, I don't necessarily need it for this, but I like to teach strategies because you want to be able to recognize the answer. You don't necessarily need to recall it, but it's nice when you're reviewing to recognize, and then eventually you'll get recall once you get the repetitions up. So now I can remember that it's posterior fossa brain malformation. See, wherever I got a hiccup, I add a little suggestion. So posterior fossa brain malformation, H is HE, which is hemangioma. This is arterial anomalies. This is cardiac defects. This is eye abnormalities. And 2 to 3 centimeters in size on the shins. So 2 to 3 centimeters in size on the shins. So we're talking about a rash. Two to 3 centimeters in size on the shins. Tender, non-pruritic, so not itchy, erythematous or violaceous nodules. So what's the diagnosis? And the answer is erythema nodosum. Okay. So erythema nodosum is what? It's tender, it's non-pruritic, it's red, and you have violaceous nodules. If you have a pathology that is a rash on the shins, you should start thinking about erythema nodosum, basically. 2 to 3 centimeters in size. And it's a delayed type hypersensitivity reaction. So the nodules would reveal like a septal paniculitis without vasculitis. So non-vertical nystagmus is often associated with peripheral causes. So vertical is central. Non is peripheral. I just like to make my next review that much faster. Cardiac index. So these are 3 categories. And so we have cardiac index, systemic vascular resistance, and left ventricular and diastolic volume of decompensated heart failure. So what would the arrows do? So for cardiac index, would it go up or down with decompensated heart failure? Obviously down. Systemic vascular resistance would be up arrow, down arrow for systemic vascular resistance. So I think it would go up, right? Because it's trying to get the blood back to the central flow. And then you have left ventricular and diastolic volume, which is up. So it's not able to escape because of the index, basically. So that's the preload. Volume overload. Yes, you get osteomalacia. So do you guys know what PBS is? It's primary sclerosis. And the associated biomarker is anti-mitochondrial antibody. And then symptoms of perioral, metallic taste, and tinnitus. So what would the diagnosis be? Just from that, you can potentially identify this one. With recent epidural anesthesia using what? Local bupivacaine, what complication inserted into the epidural vasculature. So if you put bupivacaine into the extradural vasculature, you can get systemic toxicity of bupivacaine. Right. Okay, so this question had to do with when to do a low dose, or I should just say, so if you're greater than 20 years old, more than 20 years of smoking history, then what's screening? So you should do a screening low dose CT scan of the chest. And when should you do it? If you're 50 years old or older, but ideally when they're 50, schedule an appointment. And so more than 20 years smoking history. So that's a smoke pack year, basically. Then what screening? Low dose CT chest. So what is CVT as an acronym in medicine? So it's cerebral venous thrombosis. What are the symptoms? Must be present. So if you had papilledema and focal neurological deficit. And so let's invert that question. So if you had papilledema and focal neurological deficit, what should you be thinking about in terms of diagnosis? Cerebral venous thrombosis. So I like the inverted more than I like the original question because I want to be able to identify it. So let's look at that. So that's just something to keep in mind, because if you have papilledema, that suggests increased intracranial pressure. So why do you have increased intracranial pressure with a focal neurological deficit? So you can think about, obviously there are other causes, but you can think about the cause being cerebral venous thrombosis. Okay, so this is a question where I just think it's so crucial as a doctor to know that I just added it in, and I do think that it's high yield. So I don't add many things that I won't add anything that's not high yield for increasing your score on the exam, but I just wanted to mention how clinically relevant this is and why I went into such detail. So TPN is given how? So what kind of line? So it's going to be a central line, right? So central lines can be put in for TPN. What is TPN? It's like elemental nutrition, quote unquote. So it's total parenteral nutrition. So, so what does that mean? That means that it's going to be like intravenous. So it's not a peripheral venous catheter. So it's a high osmotic load, and so it's damaging to peripheral veins. So that's the justification there is if you're doing TPN, you really need a central line, because apparently if you're a peripheral vein, you hate high osmotic load injections and boluses, and so TPN is going to be elemental nutrition. So that's the other name for it. So this is all stuff to help you like remember how to get it right on the exam. If it's elemental nutrition, it's going to be high osmoles, right? If it's high osmoles, peripheral veins aren't going to like it. So if peripheral veins are going to like it, you're going to use a central line. So that's the idea there. So what is the optimal nutritional type if your patient goes into the ICU? Like all things being equal, what would you give? So you'd give enteral nutrition. So what are examples of enteral nutrition, right? So this is something that a lot of like med students I think aren't thinking about. Like what is TPN versus ET? So ET is enteral nutrition. Enteral nutrition is like nasogastric tubes and oral gastric tubes, and you also have nasojejunal tubes, and you also have nasal duodenal tubes. And those are like your post-pyloric tubes, meaning that they are inserted to the extent that they bypass the area where the pyloric stenosis happens, which is like after the stomach. It's the like sphincter muscle that allows food to pass from your stomach into your duodenum. And so if you have those types of tubes, then you have a post-pyloric tube, which affords you the benefit of not allowing obstructions above that to be a problem getting that nutrition to the patient. So bilateral supposed septic arthritis is what? So it's transient synovitis. So bilateral, so I just want to take this apart. So bilateral, meaning both sides. And it's like supposed, meaning like, so I'm going to write that differently. Bilateral seems like seems similar to septic arthritis. So what do I mean seems like? It's like if you have septic arthritis, you're not going to get it bilaterally. There's no way you're going to get septic arthritis in both of your knees. And so if you have something that looks like septic arthritis, but it's in both your knees, you can rest assured that it's one of very few pathologies, and it's almost certainly transient synovitis. So transient synovitis is one of those, like, it's in test-taking universe, in the world of test-taking, giving something like bilateral septic arthritis is always going to be transient synovitis, which is actually something that comes up a lot on exams because they want you to identify that if it's bilateral, that septic arthritis is not the first thing that should come to mind. So pupillary dilatation in low light, and then sudden eye pain and diminished vision, halos around the lights. So what's the diagnosis? So this is really high yield diagnosis. So the diagnosis would be glaucoma, acute angle glaucoma. So can that eye become non-reactive in glaucoma? And the answer is yes, it can become non-reactive. So you have such high intraocular pressures that the eye cannot dilate, and so cannot constrict. And so even in low light, where you would want to dilate your eye, you have issues with reacting to light. So you get like mid-dilated pupil. This mid-dilated means inadequately dilated. So it's the one situation where sympathetic tone is actually going to cause dilation or relaxation of something. It's like one of the tried and true poster children for dilation in the fight or flight response, which is your sympathetic nervous system, where you're going to dilate. So you're actually going to relax muscles. But the reason for that is that you're allowing more photons of light to come to your eye so you can see more, so you can avoid predation by seeing that there's a predator nearby or something that might try to kill you. And so, or something you're trying to hunt, so you can see it. For a predator, it's life or death whether you catch the food that you would like in the wild. And so that's the justification for having sympathetic nervous system handle something like pupillary dilatation. But pupillary dilatation is going to be inadequate in the case of someone with acute angle glaucoma. And so you will have a non-reactive eye. And so that's a hint that it might be glaucoma. So it's something that does catch people off guard. So what is the test that you do for glaucoma? It'd be tonometry. Okay, so this is a question where we're talking about liver biopsy. And upon doing a liver biopsy, the question mentions that you have endothelitis, quote unquote. So I'm going to put that in quotes because it's like a cute word that they love to give and not explain what it means. But basically, you know what endothelium is. Itis means inflammation, so this is inflammation of the so that's the layer of skin that is on the inside, endothelium. So endothelitis. So the diagnosis is ACR. So what is ACR? On liver biopsy, ACR will show endothelitis, and ACR is acute cellular, specifically cellular rejection. So I'm going to put a key here, simple. So acute cellular rejection, liver transplant rejection. So endothelitis of what? It's the portal tract. So the portal tract, what does the portal tract do? It takes blood. It's basically a vessel that allows flow of blood in the liver. So what is the time course? So the time course of So I just wanted to mention that the endothelitis is the endothelium of the vasculature of the portal tract. And so we're talking about the endothelium of, not, the skin in this case, but the endothelium of a tissue that does have endothelium, which is the vasculature, and which allows blood to flow from the intestines and kind of lower digestive tract into the liver, where it can be filtered. And so endothelitis would suggest that you have acute cellular reaction, which is a very soon after transplant, so the first like 3 months after liver transplant. And what is the treatment? It's high-dose corticosteroids. So you need to know all of those things in order to get this question right. And a lot of students do get this question right. And so the question is, do they get it right legitimately? But I think this is a very high-yield question that people neglect because it's just a liver transplant. It seems niche. It's not. So uterine procedentia is basically a fancy term for entire uterus pokes through the vaginal canal. It is visible, and so if you have a uterus that is poking out of the vaginal canal, you can imagine that you're at a bleeding risk, and so this happens in older women. It's just a terminological thing. It has multiple comorbidities. So it's just pelvic organ prolapse example. Usually you feel like vaginal pressure and bulging mass. Yep. So if you had a patient that was 24-year-old male, 2 months history of cough, pulmonary nodules, and retroperitoneal lymphadenopathy, so that's retroperitoneal. So there's a whole acronym for retroperitoneal organs. So then you have pulmonary nodules, and you have 2 months of coughing. So what is your first thought? It's like neoplastic process, question mark. So you're like asking yourself, is this a neoplastic process? Because you have pulmonary nodules, right? So what type is most common in young men? Testicular cancer, actually. So testicular cancer. So fun fact about so 24-year-old male, 2-month history of cough, pulmonary nodules, retroperitoneal lymphadenopathy. So I went down a rabbit hole here on retroperitoneal organs. So we have sad pucker, right? So we have suprarenal equals adrenal glands, aorta, superior vena cava, the second and third duodenal segments, the pancreas, the ureters, the colon, the kidneys, the esophagus, the rectum. So those are all retroperitoneal organs. One of the things that is absent from that list is the testicles, but the reason that the testicles are not on that list is because they migrate. They use the gubernaculum to pull them down into the scrotum, so they actually start up where the kidneys are. And so that's why you get cryptorchidism in some patients, which predisposes you to testicular cancer. But what winds up happening is, because the testicles started in lymphatic areas which are retroperitoneal, they are still going to drain lymphatically to the retroperitoneal lymph nodes. And so that's why you get retroperitoneal lymphadenopathy in a patient that may. So your first thoughts when you have these symptoms of pulmonary nodules, retroperitoneal lymphadenopathy, 2 months history of cough in 24-year-old male should be neoplastic process. And what is the most common type in young men? Well, in this case, retroperitoneal cancer, with pulmonary nodules, is probably testicular cancer. So even in young men. And so the next step would be what? It would be a scrotal ultrasound. And so that's a really long form explanation for why it's retroperitoneal, but it's a nice way to remember it. So post-transplant, after a transplant, you see Epstein-Barr virus, PCR is positive, and you have leukopenia. So leukopenia meaning decreased leukocytes, not decreased leukopenia, but decreased leukocytes. And so what's the diagnosis? So you have post-transplantation proliferative disorder. So what does that mean? You get a proliferation of immortal B cells as a result of reactivation of Epstein-Barr. So I'm just going to draw a thing here. So you have reactivation of Epstein-Barr. So that's a herpes virus. I don't remember what number. Okay. I believe it is. Herpes virus. And high-dose immunosuppressive medications following transplantation. So the order of things is you get high-dose suppression, immunosuppressive drugs, which reactivate Epstein-Barr virus and cause the proliferation of more B cells. Don't ask me why you get a proliferation of more B cells with the reactivation of Epstein-Barr virus, but you get those, like, I know that you get those deformations of B cells, so you should have suppression of cytotoxic T cells during transplantation, which leads to like immunosurveillance, unchecked viral replication, and then the immortalized lymphocytes or plasma cells become the problem. So you have like, so I'm going to write this all out. So it's actually going to be solid organ transplantation goes to like, you get like a decrease in cytotoxic T cells. So you get increased immunosurveillance. What is immunosurveillance, you guys? I think that's when your spleen is deciding which T cells live or die. And so then you get unchecked. So you're killing more of your own immune cells in the process of the solid organ transplantation. So you get like what is called like unchecked, or like you get like increased viral replication, which it's really not replication that's happening, but it's like, although viral replication is going up, what's really happening is you have decreased, killing of these cells that are infected with viruses, destruction of viral, replicatory machinery as a consequence, and so you get immortalized lymphocytes, both B cells and T cells, but mostly like plasma cells. And so this usually happens in the context of Epstein-Barr virus. Okay. So HIV, if you had a patient with HIV, fever, nuchal rigidity, and this is a 42-year-old in this register. HIV, fever, let's say 43-year-old. HIV, fever, nuchal rigidity, CT is basilar meningeal enhancement. So basilar being the key word here. So what does basilar meningeal enhancement suggest? It suggests that actually the meningitis is tuberculosis caused. So if it's basilar, it's likely to be tuberculosis caused. So what other symptoms present on CT? You get hydrocephalus. So classically, basilar part of the brain forms a gelatinous exudate. So they like that like term, like gelatinous exudate, which is very gross. What's happening to somebody's brain is they get a basilar part of their brain forms a gelatinous exudate. So this is a place with very little immunological support. So astrocytes are your only like immunological cell in the brain. So tuberculosis getting in there is a big problem. So this person has a low CD4 count because they have HIV, which clues you in. So this is a very big clue, HIV. And then basilar meningeal enhancement seals the deal. You should be able to diagnose after that. So what type of hematoma is associated with uncal herniation? Epidural hematoma. So uncal herniation, otherwise known as coning, is epidural hematoma. So epidural, that means above the dural layer of the meninges. So what are the two symptoms of uncal herniation? You have ipsilateral, pupillary dilatation, some pupillary dilatation, and you have contralateral hemiparesis. So you have contralateral hemiparesis. So on the opposite side, you're going to be paretic, meaning you're not going to be able to move. And on the same side, you're going to have dilatation of the pupils. And this is a biconvex lens shaped imaging on imaging. So if you saw a non-contrast CT, you'd see blood where it shouldn't be, which will be enhanced in that image, and it'll look biconvex, which is to say there will be like a contact lens shaped. If you're looking at it from the side, the contacts would be facing outwards. So rapid onset, distinct spinal segmental levels, weakness, sensory, autonomic dysfunction. What's the diagnosis? So if you have rapid onset, distinct spinal segmental levels, so these are like specific segmental levels, and it's rapidly happening. Then you have weakness, sensory, and autonomic dysfunction. So you're weak, you're not able to sense the thing, your sensory input is diminished, and then you have autonomic dysfunction. So that's transverse myelitis. This is like, I think this is a weakness of a lot of people, is to understand transverse myelitis and when to diagnose it, because this is a very commonly misunderstood thing, and the best way to understand how to describe it for boards is segmental inflammation of the spinal cord. So segmental inflammation. So you're going to have signs that are very specific to a spinal segment level. It's a very hard concept. I'm going to come back to this and really describe it later. But one or more contiguous spinal segments. Contiguous meaning they're in a row, but they're not technically touching. So contiguous spinal cord segments. So if they ever mention like, oh, below the umbilicus, or at the umbilicus specifically, or like a specific like segment like C4 would kill you. You understand what I'm saying? So what is chemical pneumonitis? Chemical pneumonitis. It is not aspirational pneumonia. This is chemical pneumonitis, but it is similar to aspirational pneumonia. So how is it different? So what is chemical pneumonitis? Chemical pneumonitis is when you get like a chemical into your lungs causing inflammation, causing a problem. So this is not aspirational pneumonia where you're getting an infection from the bacteria that exists in your GI tract. This is not an infection. This is a pneumonitis. This is an inflammation due to chemicals specifically, not due to pathogens. So how is it different? So it's self-limited, meaning that you don't do anything when somebody gets chemical pneumonitis except support them, and it's not an infection. So it's gastric consonants only, it causes inflammation. So do not confuse this with acute hemolytic transfusion versus like trolley. So acute hemolytic transfusion does not involve the lungs. So just because somebody's post-transfusion or they've been intubated recently, you don't have to choose trolley just because it involves the lungs. You should think about chemical pneumonitis. And the reason you can't choose acute hemolytic transfusion is you're going to have hemolysis, right? So there's going to be a distinction between trolley and chemical pneumonitis that you'll see because they're not going to let you choose reaction if they're not hemolytic. If they don't have hematological signs, you can't choose trolley or you can't use acute hemolytic transfusion or trolley. So with trolley and acute hemolysis, I just wanted to distinguish that you're going to have hemoglobinuria and ACR and acute hemolysis, and you're not going to have that in trolley. So you might have increased BNP, but you're not going to have like an ABO mismatch or anything. So they're easily distinguishable, but neither of them are similar in kind to having a chemical pneumonitis in terms of the history and the lab work. So let's see. So this question, antipsychotic haloperidol. So also promethazine can do this, where you have D2 blockade, where in the hypothalamus, and you have hyperthermia. So when you have dopamine 2 receptor blockade, which is what antipsychotics, especially first generation antipsychotics will do, then you get hyperthermia. And so this is like classic. So D2 blockade in the substantia nigra striatum, you get lead pipe rigidity. What is that? So it's when you get rigidity in your limbs in the full range of motion. So if your arms are fully extended or if your arms are mid-flexed or fully flexed, they're still going to have rigidity across the entire range of motion. So stiffness equal throughout range of motion, diagnosis, NMS. What is NMS? It's neuroleptic malignant syndrome. Neuroleptic meaning antipsychotic. Neuro meaning neurological, leptic meaning, the limbic system, and I think that's what leptic is referring to. It could be wrong, but that's how I remember it. Neuroleptic malignant syndrome. Neuroleptics are antipsychotics. And what other antiemetic drug causes it? We mentioned this before, promethazine. Promethazine. And that does what? That is an antiemetic. So that keeps you from throwing up, but it also can give you neuroleptic malignant syndrome. So what pathology has drugs which cause this? So the answer is, if you have a patient that in the vignette says that they have Parkinson's disease, then you should be skeptical. You should be suspicious of the possibility that withdrawal from those drugs could cause neuroleptic malignant syndrome. So, in step with causing D2 blockade, when you decrease agonisms, which are agonists to the D2 receptors, which is what Parkinson's drugs do, that withdrawal is similar physiologically to having a D2 blockade. And so you will have potential to form neuroleptic malignant syndrome. SLE and CLL. CLL refers to if you were to have chronic lymphocytic leukemia, and so you have warm agglutination. So that's extravascular hemolysis. What is meant by extravascular? It's splenic macrophages eat the RBCs up. So if you effectively, so macro meaning large and phages meaning to swallow or to eat, to imbibe, and so splenic macrophages eat the RBCs up. And so extravascular, not in the vasculature, but basically in the vascular spleen. So MI inferior wall. So what are some of the characteristics of inferior wall with MIs? Is you get vagal symptoms. Which symptoms are vagal? There are 3 of them. So you can get sweating, nausea, and vomiting. So if they're vagal, you get diaphoresis, nausea, and vomiting. And what else tends to occur? You get bradycardia and atrioventricular block. So this is because, why does this happen? Well, the SA node and the AV node supplied by the right coronary artery, right? So what causes hypotension in these patients? Decreased right ventricular contractility. So just to recap, so if you get an MI that's inferior, you get vagal symptoms. What are the vagal symptoms? Sweating, nausea, and vomiting. And then what do you tend to look for? You get bradycardia and atrioventricular block, or atrioventricular block, or both. So why? The SA and the AV node are supplied by the right coronary artery. So if they don't get blood, they get infarcted or they get damaged. And so what causes hypotension in these patients? Decreased right ventricular contractility. Right, and so kidney and GI upset can result. So if you have kidney and GI upset, what should you think about doing? You get a CT angiogram, potentially. That's really vague. That's probably not true. You probably need further description of their symptoms before you get a CT angiogram. But if they seem like a vasculopath and something like that, you get a CT angiogram, and then on CT angiogram you see microaneurysms. Microaneurysms are like what you'd be thinking about with microaneurysms on CT angio. You should be thinking about PAN. What is PAN? Polyarteritis nodosa. So what affects what? What does polyarteritis nodosa affect? It affects the kidneys and the gastrointestinal tract. Okay, so that's a coupling that you should make in your mind. Just think about when you see a patient that seems to have nephrotic or nephrological pathology, and then gastrointestinal tract pathology. So at the same time. So what do you do to follow it up? You get a CT angio. And that was basically the answer potentially to a board question. Let's see. E. coli leads to, when does it resolve? It resolves in less than 7 days. So this is really important. So if you have a patient that seems like they have E. coli infection in your mind, however, they've had this infection for longer than 7 days, can you on the boards ever say E. coli? The answer is no. So what can you say? You can say that they might have Amoeba histolytica infection. And you should spell it correctly with an I. So histolytica infection. So when does it resolve? It resolves in greater than 14 days. So if it resolves in fewer than 14 days, can you say that it's Amoeba histolytica? No, not on the boards, because it has to be at or greater than 2 weeks or 14 days. So EHEC, what kind of diarrhea do you get? You get watery, non-bloody. So that should be obvious because it's not invasive. If it doesn't invade, it doesn't cause blood. So what defines a quote-unquote sustained ventricular tachycardia? It must be greater than 3 consecutive ventricular beats in a row. So sustained by definition. So this is a little dictionary icon. It must be greater than 3 consecutive ventricular beats in a row. So what rate would it have to be? It would have to be greater than 100 beats per minute. So beats per minute, so that's going to be tachycardia. So sustained ventricular tachycardia is important because if it's not sustained, then you should think about like electrolyte disturbances. But if it is sustained, you might think about other causes. So it actually gives you a clue as to what the cause is to know that it's not greater than 3 consecutive ventricular beats in a row, or it's lower than 100 beats per minute. And if it is, or if it's less than 30 seconds long, if it has any of those characteristics where it just insufficiently meets those criteria, then you might say that it's non-sustained ventricular tachycardia. And if that's the case, the underlying conditions for which predispose ventricular arrhythmia are cardiomyopathy and ischemic heart disease. But what should you think about for non-sustained ventricular tachycardia? You shouldn't be thinking about cardiomyopathy. You shouldn't be thinking about ischemic diseases, which these things are very, very serious. You should be thinking about something else that's very serious, which is electrolyte disturbances, as the cause, not the effect. So gram-positive cocci in clusters goes to apical holosystolic murmurs. Holosystolic, meaning the entire duration of systole. So gram-positive cocci in clusters. Apical, meaning so you have all people take money. I don't know if you know that mnemonic. People take money, so this is at the money area of your chest, which is the mitral area, the apical area. You're going to hear a murmur that is sustained throughout all of systole, and shortness of breath, inability to lie flat. Okay, so these are like heart failure type symptoms, or like valvular insufficiency type symptoms, or stenosis symptoms, or bibasilar crackles. So infective endocarditis is the diagnosis here. So what is MR? Mitral regurg, right? What murmur for mitral regurg? It's holosystolic, because regurg tend to be hollow, meaning the entire duration. They're not crescendo decrescendo, because that's like the cause of crescendo decrescendo would be like stenosis, narrowing. So where? The apex, right? So what grade in the murmur? When you're thinking MR, you're thinking endocarditis, right? Always, but it's a very common cause. So what grade is the murmur when MR is acute? So an acute would be low grade, right? So if you have an acute MR, that means that the grade's not going to be that high because it just happened. Now, this isn't always the case with cardiovascular disease. If something's acute, it might be more serious. But in the case of mitral regurgitation, the grade of the murmur will be low. Sometimes when things are more serious, they actually, in cardiovascular, like for example, if you had a VSD, VSD would be more serious if the murmur was lower grade. Why? Because the cross-sectional area of the whole of the VSD is going to be larger, so the turbulent blood flow is going to be decreased, so the precipitant murmur is going to be lower in volume. And so with chronic, you're going to get a high grade, and so with acute, you're going to get a low grade. So if it's been going on for a long time, it's chronic. If it's been going on for a long time, it's not as serious. If it's not as serious, it might be smaller. If it's not as serious, it might be smaller. If it's smaller, it might have more turbulent blood flow, meaning that more blood is trying to get through a smaller cross-sectional area. Like a hose, if you were to put your finger on the hose, then the water would travel more quickly, you get more turbulent blood flow if that was in a contained space. So that's how I like to think about it. So on echocardiogram, What is likely left atrial size acute MR? So normal, no time to stretch. So on echocardiogram is exactly correct, actually. It turns out that on echocardiogram, your acute MR is going to be smaller. And so your left atrial size is not going to change as a result of the MR yet, because it hasn't had time. So what is the left ventricular? So this is atrial size. This is the atrium. And what is the left ventricular size in acute MR? It's normal. There's no time to stretch. So it's the same reasoning. The atriums and the ventricles do not change in size because they don't have time. So if you have a negative adnexal ultrasound and a right adnexal tenderness, so negative adnexal ultrasound. So on the ultrasound you don't see anything in the adnexa. And then the right adnexal tenderness. So tenderness meaning to the touch. So if you were to press on it on the right side, you have pain. And then a positive pregnancy test, and vomiting, and guarding, and rebound. So you have peritoneal signs. So what's the diagnosis? So what should you be thinking about? You should be thinking about acute, specifically acute appendicitis. So when you get pregnant, one of the really, really, really high yield questions is when you get pregnant, the uterus can mess with where your appendix should be, and it folds it up and moves it, and it causes your basically appendage to get inflamed and get pissed off and mess with your peritoneum, which gives you peritonitis, which gives you peritoneal signs. So you get gardening and reflex. Rebound tenderness. And then ovarian hyperstimulation syndrome. This is just one of the incorrect answers on this question, but I think it is worth noting. What's the pathophysiology of hyperstimulation syndrome? Its VEGF is very high, and so you get overexpression of VEGF. And VEGF increased Doppler flow because VEGF basically increases vasculature, and so Doppler flow increases, and then you get increased third spacing as a result because you have more, quote-unquote, inflammation, because your microvasculature is increased. If you have increased microvasculature, you have increased fluid flowing through that microvasculature through Frank Starling forces and osmosis and that. And so it pressures, and so then you get ascites and pulmonary edema. So that's how ovarian hyperstimulation syndrome causes pulmonary edema and ascites. I think that's like super physiological, and nothing's higher yield on the exam than physiology, even though physiology is not tested as much. If you don't know the physiology, you'll still get questions wrong at a higher percentage than if you memorized a bunch of the answer choices. So I just wanted to mention that. So what are the main symptoms of Wernicke encephalopathy? It's increased encephalopathy. You get encephalopathy, ocular dysfunction, gait ataxia. So what is the mnemonic to memorize encephalopathy, ocular dysfunction, and gait ataxia? It is, the mnemonic is CAN. So I have the elephant symbol for remembering because my mnemonics are always elephant symboled. I'll never forget. So C for confusion, A for ataxia, N for nystagmus. And the treatment would be thiamine, of course, because Wernicke's encephalopathy is a early reversible pathology of thiamine deficiency, and the reversible, non-reversible, is Korsakoff syndrome, which causes confabulation and other neurological symptoms. So what does BSI mean? BSI as an acronym is signifying bloodstream infection. So BSI is a bloodstream infection. And what does CR-BSI mean? So catheter-related bloodstream infection. So catheter-related bloodstream infection, CURB-C. CURB-C. So treatment with what? Vancomycin and ceftazidime and catheter removal. Ceftazidime is a third-generation cephalosporin, and catheter removal is required. So you want to give vancomycin as one. Then you give ceftazidime, which is your second thing you want to do, for sure. And then catheter removal. Yeah, definitely charge your computer. Okay, so we're going to put a fork in this video, and we are on the 12th